Good evening, everyone. Welcome to tonight's webinar on basic abdominal point-of-care ultrasound for the general internist, presented by Dr. Irene W.Y. At the end of this webinar, participants should be able to identify the standard views used for evaluating intra-abdominal fluid and identify normal sonoanatomy of the kidneys. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Ma has no disclosures. AIUM staff members and individuals involved with planning this activity have no disclosures. During tonight's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Irene W.Y.
Well, thanks everyone for tuning in, and thank you, Kathy, for the introduction. Just to make sure everyone can hear me okay there. So in today's talk and presentation, the items that I'm going to be going over are the following. I'm going to be going over some of the basic abdominal point-of-care ultrasound uses that would be of use to the general internist. Specifically, how POCUS could be used to detect intra-abdominal free fluid, guiding paracentesis, evaluating the bladder and the renal system, and I'll touch on briefly how it might be useful in evaluating the abdominal aorta. And as Kathy mentioned, I have no conflicts of interest to declare. But however, I am grateful for the Division of Emergency Ultrasound at Mass General Hospital, where I train, for many of the images and videos that you'll find in this presentation. Let's start with a case. We have a 56-year-old female with a history of depression. She comes in complaining of a 1-month history of increased abdominal girth. She drinks about 3 to 5 beers a day, smokes about 1 pack a day, and her vitals are as follows. Her blood pressure is 118/78, her heart rate is 85, she's satting 98% on room air, and she's afebrile. So you proceed to do a cardiopulmonary exam, and it was entirely unremarkable. You then proceed to do a systematic abdominal examination. You want to inspect, you want to auscultate, you proceed to palpate, percussing. What you're trying to do is to evaluate for the presence of ascites and other potential causes of intra-abdominal girth. So really, how good is our physical examination? So based on one of the key texts by Dr. Steve McGee, in terms of maneuvers for looking for ascites, what you see here is that something like fluid wave has the highest positive likelihood ratio, and that's listed at 5.0. To put it into context, 5 is really considered a small to moderate effect size, and that's the highest likelihood ratio that we have. The lowest negative likelihood ratio is 0.2, and that's for edema. And then you kind of look at the flip side of that graph here. negative likelihood ratio of 0.2 is also only considered to be small or moderate effect size. So what does that mean, practically speaking, is that depending on your pretest probability, you still may not be able to rule in or rule out presence of ascites even after your examination. And secondly, there are definitely patient factors that can further limit the diagnostic utility of our physical examination findings. So what are our options? Well, option one, we could order some blood work for this patient and then send the patient for a diagnostic ultrasound. Really the things we're going to look for is there splenomegaly and ascites. Those are the things that typically cause increased abdominal girth that we'd be interested in. Or you can do option two and perform a bedside ultrasound right in the clinic. So let's say this is what you see. What we're seeing here is anechoic fluid that would be consistent with ascites, and you can see some bowel that's floating within the ascites. So if you see this, the formal ultrasound that you may now consider ordering would be potentially including a diagnostic paracentesis with it. Or even better, if you can actually do diagnostic paracentesis within your office, you can do it right then and there. So this would definitely streamline what you're going to do from the office setting. So let's go over what we're going to do in terms of looking for intra-abdominal free fluid. The technique for that is quite similar to what surgeons and emergency physicians do when they look for hemoperitoneum. So the examination is called focus assessment with sonography for trauma, or FAST for short. Most people know it as FAST. What you do for that examination is this. You are now ignoring the probe that's listed as number 1 there, that's looking for pericardial effusion. So for within the abdomen, what you're starting out with typically is at the right upper quadrant area. Then you move on to the left upper quadrant, and you do the pelvic region. Now for ascites, if you like, you can also interrogate and look at the right lower quadrant and left lower quadrant. So this technique for FAST, it's not really just limited to a trauma setting. And the technique that we use for this is actually very useful for any situations where intra-abdominal fluid is suspected. So this is how you're going to do a FAST scan in the right upper quadrant. You place the transducer with the marker towards the patient's head. So you can see where the transducer markers, you can't see it, but it's going to be over here pointing towards the patient's head. And you evaluate the right upper quadrant, you put it in a coronal plane, and then generally speaking, kind of anterior to mid-axillary line. And what you really want to do is kind of, you see this fanning up and down very slowly, looking through the whole region of interest. So this is kind of the scan that you're going to get. This green dot indicates the transducer marker, and then this is the plane that you're going to acquire, and these are the intra-abdominal organs that we're going to go over. Okay, so just to flip that over, what you're going to see is this is the green dot, and most screens will have that, and again that's pointing towards the patient's head, and you're going to see the liver over here and the kidney-shaped organ, which is the kidney, right over here, and you're going to interrogate through the entire area there. And then just to go over the structures that you're going to see and need to identify, first here is the diaphragm, here's the liver, and this is the kidney. Okay, so the area between the liver and the kidney is called Morrison's pouch. So where is fluid going to accumulate? Well, it's going to accumulate fairly commonly within the Morrison's pouch, in the inferior aspect of the kidney, right over top of the liver, at the tip of the liver, and also right over here by the diaphragm. Okay, so here's a clip of what ascites might look like. So what you have here is a nice region of anechoic area that suggests the presence of ascites. You've got your liver, which is on the small side here on this patient, and right within the Morrison's pouch you can see that anechoic region right there that's suggestive of free fluid, and it's going just a little bit above the liver as well. In this next video here, there is less degree of ascites, but certainly is quite well visualized. You can see the presence of ascites surrounding primarily the liver tip, a little bit less so deep into the Morrison's pouch area. And in this video here, I don't have the diaphragm visualized on this screen. I'll give you a second just to have a look at this video. The appearance of this ascites here is very different from what I've shown you earlier. Okay, so this is a patient that we had not that long ago. You can see that there's evidence of free fluid, but what's different here is that you see a lot of loculations. It's very complex looking, and you see some debris within that fluid. So this is a case of a patient with very bad pancreatitis with a necrotic pancreas, and that actually had fluid tracking all the way to the right upper quadrant. So in this next clip, I'll give you a second to look through and see what you guys think. So what we have here, an area of interest, is an anechoic region, sort of between the liver and the kidney. So the purpose of this slide really is to illustrate that not all anechoic regions are free fluid. So one of the main teaching points I want to point out is that free fluid should be pointy and not rounded. Okay, so in this video, if I just kind of advance that through, you can see that this here is quite rounded. It looks like it's enclosed within a structure. Okay. So in this setting, this patient, actually this is a contracted gallbladder, not to be mistaken for free fluid. So that's one of the tips for identifying free fluid, is that you really want to look for pointy fluid and not rounded fluid. So in this next clip, what we have here is actually the presence of both rounded and pointy free fluid. You can see that within this structure, the fluid, the anechoic region, is nice and round. This is within the gallbladder. Again, it's not important for novices starting out to identify every structure, but it is important not to mistake this for free fluid. This, on the other hand, is quite pointy looking. You can see that, and that is actually free fluid around the gallbladder. Okay, so in this clip, you actually have both. So in this next clip, again in the right upper quadrant, we have the liver and we have the kidney. And what we have here is a little bit of hypoechoic area between the liver and the kidney. What we're trying to illustrate here is the following. It's called the double line sign. What that is really referring to the fact that you have two hyperechoic lines surrounding the hypoechoic region. Okay, this is the common mimicker of free fluid in the Morrison's pouch. This is not free fluid. This is actually perinephric fat. So if it's surrounded by hyperechoic lines, don't mistake that for free fluid. Okay, so we've sort of covered the right upper quadrant here. Let's move on to how the technique looks for the left upper quadrant. So the technique is actually relatively similar. What we have here is the patient's head on the right-hand side of the screen and the patient's feet on the left-hand side of the screen. So the probe marker is pointing towards the patient's head again. So your technique is otherwise similar, except for the fact that you're going to start out actually very posteriorly, closer to the posterior axillary line than the mid and anterior axillary line. But the technique is otherwise the same. You do want to fan through the area of interest in a very similar manner, and you want to go scroll up and down through that. So what you're going to see is you're going to make a section of the slice like so, and then again with the transducer marker over here, you're going to see some intra-abdominal structures that look very similar to this. What you have here is the spleen over here, kidney over here, diaphragm over there, and then you see a little bit of lung coming in as the patient inspires. The splenic hilum is kind of the hyperechoic area in the middle there. So once again, the structures of interest, you really want to identify the diaphragm, the spleen, and the kidney, and where is fluid going to hide out. Now, in the right upper quadrant, I talked about Morrison's pouch being an area of where fluid could accumulate. This is not the same case in the left upper quadrant. In fact, because of the way ligaments are located in the body, specifically there's one called the phrenicocholic ligament, fluid doesn't tend to accumulate here, so it's kind of a lighter yellow. Where it tends to accumulate is actually just at the spleen tip and above the spleen. Okay, so these are the areas that you want to look for when you're evaluating for ascites or free fluid. What we have here in this clip now is obscured by a rib shadow, but nonetheless it's fairly easy to make out that there is clear anechoic free fluid, because see how pointy that is. You can in fact see this free fluid tracking all the way above the spleen right here. Okay, so this is definitely a positive left upper quadrant scan. In addition, and not really related to this talk, this patient also happens to have pleural effusion on that side as well. So sometimes when you are scanning the left upper quadrant, you might come across very unusual findings. So this is a scan from a 74-year-old female from India. Her left upper quadrant looks like this. Okay, so what we see here is very, very heterogeneous looking appearance, mobile structure here. Really, what might be the problem in this patient? So whenever I ask this question of my trainees, things related to splenic lesions, TB, and such would show up as possible answers. Now, the main teaching point I have for this slide, for this video, is that really when you're evaluating the left upper quadrant, the first question I would ask of this clip is, where is the kidney? So what you'll notice is that you don't want to jump into conclusions and start analyzing scans. Always go back to your landmark. So I can't really see the kidney very convincingly in this clip. So let's go back to basics and evaluate and actually look for the same patient's kidney. Once we have found this, it's pretty evident that the spleen is actually fairly normal looking. Okay, so that's really the teaching point of that, is that before you start analyzing, making calls, make sure to always go back to your landmarks. Okay, so we just kind of completed the left upper quadrant. Let's move on to the pelvic views. So what we're going to do here is that we're going to start out by scanning the bladder transversely, sweeping up and down, and then we're going to do a longitudinal scan, sweeping from side to side, like so. So here's a transverse view of the bladder, like that, and then you're going to sweep and change to look for a longitudinal view of the bladder, and you want to sweep from side to side to really evaluate it. Let's just make sure we go over the anatomy so we really kind of know what we're looking at here. So anatomically, you've got your longitudinal plane cutting through, and this is a male patient. You have your bladder, you have your prostate over here. The green highlights are seminal vesicles, which show up in the transverse plane. So in a longitudinal plane, this is what it's going to look like. You can see the bladder, which is the anechoic rounded structure, and you have your prostate coming in there. In a longitudinal view, what you're going to see is, again, the bladder over here, some of the hypoechoic areas, rounded structures here, those are seminal vesicles, and then you can see the prostate later on there. Where does fluid hide out in the pelvic region? Well, generally right behind the bladder, kind of highlighted in yellow. That's the rectovesicular space that the fluid is going to accumulate in. And that's what it would look like. You've got your bladder, rounded bladder, and pointy fluid. That's what you're looking for just beneath the bladder. And in a transverse plane, it's actually harder to pick out because you're not looking at a long stripe of fluid. You're cross-cutting it. So if you happen to have a small amount of fluid, it may be very difficult to identify. And you don't want to mistaking the seminal vesicles for intra-abdominal fluid. So generally, the longitudinal view is preferred for truly identifying fluid. But if you have large amounts of fluid, it will show up quite nicely in the transverse plane as well. Female anatomy, you have the bladder here, uterus over there, and that's what a longitudinal plane is going to look like. You've got your uterus over here and your bladder over there. And in a transverse plane, this is what it would look like. And you can see the uterus as it comes in through there. Where does fluid hide out? It's going to hide out in the pouch of Douglas, in the rectal uterine recess right here. And that's the same space for your transverse view. So you can see here, fluid tracking up the uterus. Fluid going up a third of the uterus could be considered physiological, but anything more than that would not be consistent with physiological fluid. And then in the transverse plane, you've got your uterus, and then right here you can see a glimpse right there of that fluid just underneath the uterus. So again, generally, a small amount of fluid is much harder to detect in a transverse plane than it is on a longitudinal plane, and these are the same patient. Okay, so in this clip, you can clearly see a large amount of, well, moderate amount of ascites kind of surrounding the bladder. You can see a bit of bowel over here. So this is, again, a positive pelvic scan here. In the same patient, doing a longitudinal plane, you can again see the free fluid right here, right there. Okay, so again, this is another positive view. What are some ways that you can do to help improve the sensitivity of your exam? Well, one is that if you're looking at the right and left upper quadrant, you can improve the sensitivity by just placing the patient in Trendelenburg. This way, any fluid is going to go into the upper portion of the body. You have a higher likelihood of detecting fluid. For the pelvic scan, your sensitivity goes up if you actually put the patient on reverse Trendelenburg. And that way, again, that will kind of get all the fluid using gravity to get it more into the pelvic region, and that might be easier for you to identify the intra-abdominal fluid. So how else is POCUS helpful? Once you've identified ascites, for those of you who are hospitalists or those who have the capacity or ability to do procedures within your office, you can use ultrasound to help guide your procedure. So what you have here are, these are the kind of general left lower and right lower quadrant landmarks that you might use blind. What you can do is you can actually use the ultrasound to really have a look at the area that you were going to perform the paracentesis to make sure that your pocket is really large enough. So one is that two things I look for. One is that I really want a pocket that's big enough and consistently big enough. So you don't want bowel coming in and out. So certainly, like right here may not be the best choice. You probably want to have a pocket of fluid where it's consistently, there's no bowel in your way, and you really can access the fluid safely. Second thing I want to really evaluate is the presence of organs. I always tell my trainees, even though you're in the lower quadrant, I want them to demonstrate for me where the edge of the liver and the edge of the spleen would be, because in massive splenomegaly, you certainly can have spleen as low down as the left lower quadrant, and you certainly want to avoid intra-abdominal organs. So ultrasound is super helpful in identifying a pocket big enough, and secondly, making sure that you're far away from bowel and intra-abdominal organs. The second really helpful thing that ultrasound can do is help you identify, or at least try to avoid, the inferior epigastric vessels. And these are vessels that could potentially pose problems with bleeding. And what you can do is, what I've done here is I'm using a linear transducer. You could probably do the same thing with abdominal curvilinear probe, but you want to decrease your depth of view, so you're focusing in really only on the skin and subcutaneous tissues and muscle areas. And what you do is you put on color Doppler and you look for vessels. So if you happen to see vessels lighting up, that's certainly an area you're going to try to avoid. Now, it's important to know that for color Doppler, if you're exactly at 90 degrees to the vessel, you may detect no flow even though you're right over the vessels. So you really want to make sure that you're angling the probe either towards the feet or towards the head to make sure that you pick up flow appropriately. And this is based on Doppler principles, which is beyond the scope of this talk. If in doubt, one other option is to do a power Doppler, and that one picks up slower flow, but it's not angle dependent. So if it doesn't matter how you tilt your transducer, you should still be able to pick up any flow and problems that might be just underneath the transducer or where you want to insert your needle. The problem with power Doppler is that it's very sensitive, so it's very subject to what we call flash artifact. That means that if you move the transducer even a little, the whole thing will light up, and it makes it very difficult to interpret. But as long as you have very, very steady hand motion, anchor your hand on the patient, you should be able to identify these vessels and try to avoid them. Now, do I make my trainees find a vessel so that they know where they are to try to avoid it? I don't usually. What I do try to get them to do is to make sure there is no vessel where they want to stick the needle in. So why am I going on about using ultrasound for paracentesis? We've all been doing paracentesis forever without using ultrasound. Complications aren't that great. There are studies that show that ultrasound, despite a low risk to start with, the ultrasound further decreases your bleeding complications. So in this study from 2013, the relative risk of bleeding complications is 0.27. What that means is a 73% reduction in the risk of significant bleeding. Furthermore, in that same study, they found that by using ultrasound, or I should say by not using ultrasound, primarily because of the bleeding complications, your hospitalization costs dramatically and significantly increased, and your length of stay also significantly increased in the population that did not have ultrasound guidance. Let's move on to case 2. We have a 79-year-old gentleman with acute kidney injury and a creatinine of 5.1. So you go ahead and scan the bladder. It's the same method that we already talked about, doing the looking for intra-abdominal fluid, and you see this. So what we have here is a distended bladder with an enlarged prostate. So let's go over how to calculate bladder volume. You can use one of a number of described formulas. The one that I use is from Vicky Nobo's textbook, which is to simply multiply the width by the length by the height meaning AP diameter, and then apply a correction factor, which is 0.75. So here in a longitudinal or sagittal view, this here gives you the length of the bladder, and then in a transverse view, you're going to get the width of the bladder and the height, which is the AP diameter, multiply those three numbers together, and in this patient, there was 909 cc's. Okay, so there you will see different formulas used, in that there are pros and cons to each of those depending on the sensitivity and specificity that you want in identifying urinary retention. But really the bottom line is that POCUS is very, very helpful in terms of reducing the inappropriate use of urinary catheter, and that's in concordance with the guidelines from the Infectious Disease Society of America. We really should be only using urinary catheter when indicated, and at a evidence level B2, we should be using portable bladder scanners to determine whether or not you should be using urinary catheters. Let's move on to case 3. It's now Sunday evening. You're in the hospital. You're on call. You're seeing an 84-year-old gentleman with acute kidney injury, except this time the creatinine is 12. And you scan through the right upper quadrant, doing the view that we talked about in the right upper quadrant, except this time you're focusing a little bit more on the kidney itself, and you see this. And this is this gentleman's left upper quadrant view of the kidney. Spleen here, kidney there. And then when you calculate the post-void residual, using the same calculations that we talked about, it's 67. So what do you think might be going on? What we saw was a lot of anechoic region within the kidney. So let's kind of touch on what the kidney anatomy looks like. Okay, so you have your renal parenchyma, which is outlined in orange here, renal cortex in blue, and then the hypoechoic areas that are kind of triangular shaped would typically be the renal pyramids. Okay, so that's what on an ultrasound a kidney might look like. What we have again here is the renal cortex in blue, and then the anechoic or hypoechoic triangular shaped pyramids over there. Okay, and then within the pelvis of the kidney, what's in green there are a number of structures. So you have in blue would be the minor calyces, and then in orange would be the major calyx. Now, the calyces don't usually show up unless the patient has hydronephrosis. So what you typically only see on ultrasound is this hyperechoic region within the renal pelvis. Okay. However, in the presence of hydronephrosis, you're going to see anechoic areas within the pelvis of the kidney. Okay, so this is what we call grade 1, where you just kind of see a little bit of anechoic area within the renal pelvis. Now, the clinical significance is often debatable. If you have a patient with a very brisk diuresis, just got a large dose of furosemide, you might see this, or if a patient that's holding a bladder hasn't peed for a while, you might see this. It may be of no clinical concern at all. Now, in grade 2, what you're going to see is you start seeing the dilation of the minor calyces. In grade 3, then the major calyces start dilating. Okay, and then what you then progress onto is very severe, which is what we call bear claw appearance. It kind of looks like a bear claw, and really thinning of the renal cortex, which then the presence of which suggests some chronicity to this whole process. Okay, so this is kind of a views of what they all might look like. You can see a tiny trace of hypoechoic area there in grade 1. Grade 2, you might see a little bit of dilation of your minor calyces right there. And then here you have grade 3, where some of the major calyces are now also easily visualized as anechoic, and then progressing to a bit more severe picture. So again, that's kind of what we had on our patient in the right upper quadrant, which suggests that this patient might be obstructed. And that would be very important to know. Now, what are the pitfalls of making calls on hydronephrosis? So let's say you have a patient here, and this is the kidney scan that you obtain. You can see some anechoic areas within the pelvis of the kidney. So it's helpful, I think, for all patients, ideally, is to put on some Doppler to make sure that what you're looking at actually isn't just renal vessels. You don't want to mistake anechoic areas within the pelvis, call it hydronephrosis, when all it was just renal veins that you're seeing. Okay, so that's one of the major tips that I have. Use Doppler to reduce false positive rates. It helps improve and increase your specificity. Okay, so here's another patient that I saw, and you can see that in this patient, again, clear anechoic region extends all the way to the minor calyces. And throw on Doppler, there's really no flow, so I'm not looking at an enlarged renal vein here. And then scanning further down on this patient, you'll see the bladder scan here. And what you see here is lot of hyperechoic material within the bladder that you can see. And again, this is beyond point of care, but of interest, there's also hyperechoic area within the left ureter on this patient. Here's another view of the same patient. Here is the balloon of the urinary catheter. But what you can see, really, the main thing here is that you see a lot of debris within the bladder itself. And then you can see dilated left and right ureters with echogenicities within those structures. And this patient ended up having transitional cell carcinoma. I'm going to go over our last case here. So what we have is a case, 76-year-old gentleman with a history of diabetes, hypertension, remote MI. He smokes half a pack a day and drinks minimal alcohol. You're seeing him in the office. We're back in the office now for hypertension. So you kind of sorted that out, and just on his way out, the patient kind of raises this point and said, "Hey, gee, doc, I don't know if this is important to bring up, but just a couple times this week I had some discomfort in my abdomen. I don't know what to make of it. It's now 5 o'clock and you're, on a Friday, this is your last patient of the clinic, and obviously in an elderly patient who's a smoker, you are concerned about abdominal aorta. How concerned should you be? Well, we all know the limitations of physical examination techniques in terms of trying to sort out whether or not patients aorta is enlarged. What does the data say about the ability to identify abdominal aorta on physical exam? Well, in a thin patient, the sensitivity is 91, specificity 64%, but in a patient with abdominal girth more than 100 centimeters, your sensitivity dramatically goes down to 53%, so that's probably not a whole lot better than flipping a coin here. So you turn to your ultrasound and you scan the patient and you end up seeing this within the abdomen. And this is a longitudinal view, and you do a measurement of the structure, and it's 5.3 centimeters. So if you find that, it really changes the urgency of how quickly you want this patient evaluated and where you want this patient evaluated. Certainly in a symptomatic patient with identified abdominal aortic aneurysm, the urgency is much higher than in a patient, who has a normal aorta. Before I go too far here, I wanted to comment on one thing. So unlike all the other examination techniques that I've described earlier on in this webinar, the learning curve for abdominal aortic aneurysm exam is quite different. So specifically that the plateau points, and what this means is percent agreement between people who are training and expert reviewers, and the number of times to do the ultrasound. So what they're looking for here, sorry, just to go back, is at what point do you stop improving in your scans, that your scans become acceptable. So in this study, what they found was that on average the interpretation starts to plateau, meaning that learners will be interpreting about 66 scans before they can correctly identify findings, roll in or roll out findings. And in terms of actually acquiring the scan, the plateau peaks at, or it plateaus at much higher at 84 scans. So it's really one that is a harder exam to do, and I certainly don't want people to come out of a weekend course and think that they, are completely competent at evaluating the aorta. Having said that, it's not an impossible skill to learn, and with adequate training, this is certainly a possible examination to learn. So in this study here, in a family medicine resident physician was able to achieve in the office quite decent accuracy, and this is someone who is well trained. So I'll briefly describe the technique here just so that you know what you're looking at. So what we have here is that the aorta with the celiac axis and the superior mesenteric artery, or the SMA. Your renal vessels branches off just beneath that, and most of the abdominal aortic aneurysms are going to occur in the infrarenal region. Okay, and then as you go down further, the major branches that you're going to look for are the iliac arteries. So technically this is what it would look like. You want to do a transverse section here and really scroll down and scan through the abdominal aorta. You can see the aorta here, and eventually it's going to branch into 2 iliac arteries. Just to briefly touch on what the anatomy looks like. So again, at the point where the celiac access with those 2 branches, so you can see that right there. But really the main teaching point I want to make is that never call any circles in the abdomen aorta until you can convince me that you have found the spine, because you don't want to be mistaking this for the aorta if your depth wasn't deep enough. So first identify the spine. And then what you have on top of that, on the right side is the aorta, on the other side, on the patient's left-hand side or right-hand side of the screen is the aorta, on the other side is the IVC, and there are other features that you can look for to tell the difference, such as thicker wall, the way it's pulsating. This varies with respiration, and it's maybe a bit more compressible. And then once you've identified that and the celiac axis, you know you're in the proximal part of the aorta. And then as you scroll down further, you're going to see this, where you get a little circle above your aorta, and this would be the superior mesenteric artery, and then you have your renal vessels branching out there. And then as you scroll down even further, you're going to see the branches, the iliac vessels. So the main thing with the aortic examination is that you really want to be thorough, and you want to scan adequately through the entire aorta, through from the proximal all the way to the bifurcation. Then you want to do a longitudinal view just to make sure you can see the aorta sufficiently. And what you see here is that you have the aorta in the longitudinal plane and the SMA branching out there. An aneurysm is defined as anything at the structure greater than 3 centimeters or more. You really want to measure from outer wall to outer wall. You don't want to measure at the edge of the anechoic region, because what you might miss is a thrombosed intramural thrombosis. That's actually part of the aneurysm itself. So if you miss that, you might think the aorta is only 1.54 centimeters, but if you actually measure it properly, this patient has an abdominal aortic aneurysm, which is at 3.45 centimeters. Why is abdominal aorta scan so challenging? Well, oftentimes when you put the transducer on, you're going to see a bunch of gas. Okay, so patient bow is definitely a concern. You'd want firm pressure, graded pressure on the patient, but that doesn't always solve the problems. And secondly, patient cavities really does this make examination quite challenging. So I think those are some of the reasons why it does require a bit more training before you should even consider using that, but I think there is definitely clinical utility in both in the office and in the hospital setting for appropriate triaging of the patient. The main thing is to not undercall things and not to mistake and miss an aortic aneurysm. So we've sort of covered the following. We've covered the technique in looking for free fluid. We've also touched on what are some of the pitfalls and what are the things you really want to look at. The pointiness of the free fluid, you want to make sure it's not bordered by hyperechoic areas. Those are the things that can fool you. We talked about the utility of using ultrasound to guide your paracentesis procedures. Despite being trained in a blind fashion, I really very uncommonly would I proceed with a paracentesis without having looked at the abdomen and the ascites itself with ultrasound. We've also talked about bladder scanning, sorting out the volume of the bladder, what hydronephrosis would look like on the renal scans, and touch on very briefly some of the techniques on evaluating for abdominal aorta. So I'd be happy to, I think we have 15 minutes left, so I'd be happy to entertain any questions if there are any, and if not, my contact is listed on the slide here.
So Dr. Ma, it looks like we have one question. Are you able to see it?
No, I cannot.
Okay, the question, I'm
Oh,
just,
sorry, there it is.
you see it? Okay.
Yeah, I can see it. Thank you.
Sure.
You recommend any specific resource for a novice internist to learn the basics of ultrasound machine and the maneuvering of the probes? Yeah, I think there are definitely a number of very good resources out there, and I have no conflict of interest with advertising any of these resources. In terms of textbooks that I recommend, I definitely do recommend Vicky Novo's textbook on emergency ultrasound. Sorry, that's Vicky Novo along with Brett Nelson. And also Rob Arnfield and Neil Sony also has a very good general internal medicine POCUS text that might be helpful. But really, I think one of the main things is that you do want multiple resources to help learn this skill. It's not only from a textbook, it's not only from a webinar, it's not only from attending conferences. You want hands-on time with the transducer and really try to get feedback on your imaging so that you know what you're looking at. So I have another question here. It says, out of interest, what did the patient from India end up having? That patient actually ended up having nothing. She was totally fine. She had a completely normal point-of-care ultrasound. And because she did come in with abdominal pain, further investigations were done, and she actually still didn't end up having anything. It was a completely normal evaluation. Her pain did resolve, so there were no concerns on that patient. But you just never know, which is kind of the reasons why we do point-of-care ultrasound. The next question I have here is how to quantify free fluid in the abdomen. That's actually a really good question. Can you guys still, Kathy, can you still see?
Yes, I still see your screen.
Okay, sorry. Yeah, sorry, my slides there. Okay, so I think I'll have to, I hope you can see sufficiently. This is kind of a smaller slide here. I didn't go over this in my talk, but there are a number of ways that you can quantify fluid within the abdomen. I like this approach that I have on the slide here, and what you're really looking for is what they call the smallest fluid depth. So what you want to do is identify the depth of the fluid that's at its smallest. So this kind of, the bow that kind of juts up, you want to find the smallest possible pocket, measure that depth, and in this case it's about 5.3 centimeters here. So what that study showed is that if you have about 5 centimeters, that translates typically to having about 5 liters of drainable fluid. And in that study, what they found, and what you can see here, is a linear correlation of the smallest fluid depth on the x-axis and the drainable fluid volume on the y-axis. So what they found there is that for every centimeter increase in that depth, you can add another liter to your estimate. Obviously, these things are not perfect, like it's not going to perfectly correlate, but it gives you an idea how much fluid is in the abdomen. There are other methods of quantifying free fluid as well, so this isn't the only method out there. So there are other things like ascites index that you can use. Some of the surgeons would add up the number of regions on your FAST scan that are positive, and the more regions there are, the more higher the index for fluid. So I think a number of techniques are used or considered. I don't think at the end of the day we're very good at exactly quantifying the amount of fluid, but I do use the 5 centimeter cutoff, primarily because I think that does suggest you have a large number of liters of drainable fluid. Is there a formula for estimating the amount of fluid? So we just covered that. Are there any particular hands-on courses that I would recommend. Yeah, I think that I can certainly look up a number of courses that I would suggest you could certainly consider. Feel free to email me some of those. I think it's difficult because I don't think that any course I can say confidently who's teaching it and who the instructors are. So I don't think it's super easy to really definitively comment on all the courses that are available out there. But certainly, for instance, like WinFocus has a number of courses that you can consider. The annual meeting at AIUM has some hands-on workshops that you can consider. Within Canada, we have a number of emergency ultrasound courses that are available as well. But really the main thing that for any given course, really what you want to look for is just to make sure that it's not biased. You want to make sure that you get sufficient hands-on time and the instructors know what they're talking about. And then in this next question, what structures make up the double line sign? To be honest, I don't know for sure exactly what are the boundaries, but really it's the perinephric fat likely bounded by the gerhodus fascia from the kidney and the liver capsule. But I don't think I definitively know the answer to this, but based on my assumption, that's kind of what I've always thought would be causing the hyperechoic areas that we're seeing on the lines. So in terms of, just back to the question for the hands-on courses for the novice internist, I do think actually the person added the internist aspect to the question. I think that is relevant because I think oftentimes the skills that are learned that are useful for another specialty may not be as practical or as of use to us as internists. For instance, at least I don't do I don't do any nerve blocks in my practice, so some of the items that typically show up in many workshops don't show up or aren't relevant to me anyway as an internist. Of interest though, you should also look at ACP. I know certainly for I think at least 2 years in a row they've offered POCUS workshops for general internal medicine, and those are other forums you can definitely consider.
So I think that's all of the questions, Dr. Ma, and I will thank you so much for this excellent presentation. Also, thanks to all of you who participated tonight. Everyone, please remember to complete the post-test and the activity evaluation. We hope you enjoyed this evening's presentation, and please join us again for future webinars. Good night, everyone. Have a great evening.
Thank you.